Hi there, learners out there in YouTube land. It's Dr. Suchard again with a short video discussion about anti-epileptic drug toxicity, corresponding to Chapter 48 in Goldfrank's Toxicologic Emergencies. The learning objectives for this session are that you'll be able to describe the primary class effect toxicity seen with anti-epileptic drugs, identify at least 3 of the most common currently used anti-epileptic drugs, since these are going to be the ones that we're most likely to see toxicity from, and to name the only anti-epileptic drug with a specific antidote available. The anti-epileptic drugs all have the same goal, to reduce seizures, but they have a few different potential mechanisms of action, and some of these drugs rely on more than one of these mechanisms. There are those that block sodium channels, preventing uncontrolled neuron action potential generation and propagation. Some block N-type calcium channels, or block fusion of synaptic vesicles containing neurotransmitters, and others block various excitatory amines like NMDA, kainate, and AMPA. Those drugs that I see patients taking most commonly are highlighted in pale blue boxes, but what's not even depicted here are the sedative hypnotic agents like barbiturates and benzodiazepines that increase GABAergic tone. While these medications are definitely used to acutely control seizures, they are no longer relied upon for chronic seizure suppression therapy due to their more profound sedative effects. And here on the right, I've listed some of the most common brand names for these medications in the US. There's loads of patients now taking Keppra, levetiracetam, many taking Depakote, which contains divalproex, which is a form of valproic acid. Dilantin is the common name for phenytoin, and I've also listed Tegretol, the brand name for carbamazepine. One of the troubles in talking about anti-epileptic drugs as a group is that the number of them continues to increase, and there are changing practice patterns where older drugs get supplanted by newer ones. A few old-timers may persist, while some of these drugs are only used very rarely. This would be a very boring and repetitive discussion if I tried to go through all of these agents individually. So I'm going to focus on some general statements that are widely applicable, and then hit some specifics only for a few agents. Since the purpose of an anti-epileptic drug is that it should calm excitable nerves, it makes sense that CNS depression can commonly be seen with overdose, and that's about the only thing that applies across the board as a class effect toxicity. For several anti-epileptic drugs, we can get stat drug levels for them by sending blood to the clinical laboratory. Getting these levels can be helpful in drug toxicity situations so that you can follow serial levels that could guide what level of monitoring a patient might need, or help determine when the toxicity has peaked or passed and the patient should be safe for discharge. Not very long ago, we pretty much only used anti-epileptic drugs for which we could get stat drug levels. If any drug has a serum level that we can order routinely, that implies that therapeutic drug monitoring is probably needed, which further implies that the therapeutic index of the drug is relatively low, such that we need to be able to follow the drug level to avoid going just a little bit too high and causing toxicity. But several of the newer drugs either don't yet have levels we can order rapidly, or we don't really need to, because the therapeutic index is so high that it's virtually impossible, in the absence of an intentional overdose, to make a patient have serious toxic effects. You just titrate the dose up to get the desired effect of seizure suppression, and the exact serum level is immaterial. Currently in 2024, levetiracetam, or Keppra, is the most common anti-epileptic drug being used, and it's pretty safe. The biggest problem with Keppra, which is shared by every one of these drugs, is when the level is too low and the patient has more seizures. Just about 15 to 20 years ago, phenytoin, common brand name Dilantin, was the workhorse of anti-epileptic drugs. Nearly every patient being treated for seizures was on Dilantin, and the few who weren't were getting phenobarbital. Phenytoin had a good run of around 5 decades as the preeminent anti-epileptic drug, and then carbamazepine and valproic acid had their time in the sun, and you'll still see different patients taking all of these medications. Phenytoin had a couple of big problems, which is why it's not as commonly used today. First, the drug metabolism gets saturated near the top of the therapeutic range of 10 to 20 milligrams per liter. For some patients then, very minor changes in dose or drug metabolism, including through drug interactions, could have their phenytoin levels shoot up into the toxic range quite easily. And if a patient needed immediate IV medications to control seizures, you could give phenytoin IV, but this required cardiac monitoring due to the drug's penchant for cardiac sodium channel blockade, and it was compounded in a very basic solution to keep it dissolved, And if the IV phenytoin extravasated, got deposited into tissues surrounding the vein instead of only into the vein, it could cause serious soft tissue injury called purple glove syndrome. The only other single antiepileptic agent I'm going to mention in this video is valproic acid. Valproic acid itself is a short branched-chain fatty acid, and it can interfere with fatty acid metabolism, resulting in carnitine depletion, liver injury, pancreatitis, and elevated serum ammonia levels. This is all detailed in another video in this series about carnitine as an antidote, so why not watch that video next? Nearly all antiepileptic drug toxicity is treated by stopping the medicine and providing symptomatic and supportive care as necessary, while the patient's body eliminates the drug. There's more that could be said, but I'm not going to say it. I'll be seeing you around.